Welcome back to the deep dive. This is where we take on some of the most challenging and complex fields of knowledge, really strip away that dense jargon, and give you something synthesized and actionable.
And today, we are really undertaking a massive one. We're diving into the absolute control center of, well, everything. The central nervous system, the
The
CNS.
CNS, the brain and the spinal cord, it's the conductor for literally everything that makes us who we are. It's our thoughts, our movements, every single thing we feel.
Right. And when that system is compromised, the effect isn't just, a symptom or some discomfort. It's a profound change to a person's entire self. And it requires this huge coordinated effort to manage.
Exactly. We had a stack of incredibly dense medical and pharmacological sources this week, and our whole mission here is clarity. We're going to distill the core concepts and the most critical, practical takeaways for some major CNS conditions.
And we're splitting it between the brain, the center of cognition, and the spinal cord, which is really the highway for movement and sensation.
To kind of set the stage for this, the source material was really clear about prioritizing certain, let's call them foundational human functions that get hit by these disorders.
Yeah.
So for the brain, what were the two big ones we need to track?
For the brain, the two dominant priority concepts are cognition and mobility.
And that's such a key link, isn't it? Because you hear brain disorder and you immediately think about, well, thinking, but the ability to move, to just walk around, that's just as compromised.
Precisely. And that connection gets even clearer when we shift down to the spinal cord. For the spinal cord, the priorities were, again, very strong on mobility, but they also added immunity.
Immunity. Why that?
Because a spinal injury or inflammation, it can have these profound effects on your whole system's function. It's not just about being able to walk.
Got it. And as we go through all this, we have to keep these themes in mind. It was so clear that across all these topics, brain, spine, all of it, certain, really painful daily human experiences kept coming up.
Yeah, common threads, things like pain, infection, big changes in sensory perception, and even sexuality.
This isn't just biology we're talking about. It's life.
That's the core insight, really. A CNS diagnosis is never just one isolated symptom. It fundamentally challenges a person's ability to think, to move, to feel, to even maintain relationships. So understanding that coordination of care is what we're focused on today.
So where are we starting?
We're starting with the one that maybe most tragically attacks human cognition, Alzheimer's disease.
Okay, let's unpack this first big section. Alzheimer's disease, or AD, it's the most common type of dementia, and the sources start with a definition that is just non-negotiable.
Right. It is explicitly, emphatically not a normal part of aging.
That's a distinction we really have to hammer home.
Absolutely. Normal aging might mean, it takes you a bit longer to find a word. Alzheimer's is a relentless, destructive, pathological process. And to get it, we have to talk about the physical changes that are driving that destruction.
The sources pointed to two main pathological markers.
Yes. Two things that defined AD in the brain: the presence of neurofibrillary tangles and neuritic plaques.
I think we need to slow down and really clarify what those are, because they just sound like vague scientific terms, but they are literally the agents of destruction here.
They absolutely are. So let's start with the neuritic plaques. These are sticky, abnormal clumps of protein, specifically a protein called amyloid beta, and they form outside the neurons.
Outside the brain cells.
Right. Imagine it like a kind of biological cement that's being poured between the brain cells.
Yeah.
These plaques just get in the way and interfere with the synaptic communication. The whole messaging system between the cells starts to fail.
Okay, so that's blocking the signals externally. What about the tangles?
So the neurofibrillary tangles, they do their damage internally. They are twisted, insoluble strands of a protein called tau, and they build up inside the neurons.
And what does tau normally do?
Normally, tau protein helps stabilize the neuron's internal structure. Think of it like the tracks for a railway system inside the cell. But when tau gets twisted up into these tangles, the tracks buckle, the whole structure collapses, and the neuron's transport system just fails.
Wow. So you've got communication being blocked outside the cell by the plaques.
Right.
And then the cell itself is dying from the inside because its internal structure has just collapsed because of the tangles.
That's it. That combination is a guaranteed recipe for widespread neuronal death. And that leads to the brain atrophy, the shrinking that defines Alzheimer's.
The scale of this problem is just staggering.
Right.
I mean, the sources said it can affect people older than 40, but it really skyrockets after 65.
Yeah, the numbers were specific. In the U.S., it's about 1 in 9 people over the age of 65.
That is a massive, massive societal burden. And with a disease that prominent, you have to ask. I mean, researchers are always looking. Why did the sources stress so clearly that there is no proven way to prevent AD? That feels like a really important reality check.
It is a critical distinction. It means that despite a lot of promising research, there is no single drug, no vaccine, no supplement that has been definitively proven to stop the underlying process, the plaques and tangles, from ever starting.
So primary prevention, stopping it before it begins, is not on the table right now.
Not yet. So when we talk about prevention efforts, what we're really talking about is mitigation. It's about minimizing the contributors to brain decline.
Trying to slow the overall impact.
Exactly. The efforts revolve around optimizing everything else that affects your brain health, especially your vascular health. So that means rigorous, lifelong management of chronic problems like high blood pressure, diabetes, high cholesterol.
So managing your blood pressure isn't actually stopping the plaques from forming,
No,
but it's making sure that the parts of the brain that haven't been compromised yet have the best possible blood flow and oxygen to keep functioning.
precisely. You're building resilience around the inevitable pathology. And of course, you add the other pillars, a brain-healthy diet, consistent exercise, both physical and mental, and stopping things we know are damaging, like smoking and excessive drinking.
All right, so moving on from the pathology, let's get into the progression. It's broken down into 3 stages, which really helps caregivers anticipate what's coming.
It's a roadmap, really. It helps everyone understand the increasing demands on the patient and, the whole care system.
Okay, let's start with stage I. This is the early or mild stage. The materials said it can last up to 4 years. What's the key characteristic here?
The absolute defining functional characteristic of stage I is that the person is still independent in their activities of daily living, or ADLs.
So they can still feed themselves, get dressed, take a shower.
For the most part, yes, they can manage without a lot of assistance. But the first behavioral cue that the family often picks up on is denial. They might actively deny they're having memory lapses, or they try to cover up their trouble with finding a word or organizing things.
Because they're still aware enough of their deficits to be embarrassed or scared by them?
Exactly, and that awareness must be just agonizing. Then things really shift in stage 2, the middle or moderate stage.
And this one lasts 2 to 3 years, typically.
Yeah, and this is often the longest and most challenging stage for the family, because the shift to dependency is so profound. Stage 2 is defined by the impairment of all cognitive functions. We start to see a loss of abstract thought.
The sources specifically mentioned handling money, right?
Yes, problems with finances, things that require complex sequential steps, that becomes incredibly difficult. And their physical world starts to fail them too.
Those visuospatial deficits.
Right. The brain's ability to process where you are in space, how far away things are, it just starts to break down. That's why we see difficulty with driving. And they often get lost, even in places they've known their whole lives. Their internal map and clock are just gone.
And the emotional side of that must be immense. What kind of changes do you see there?
Depression is extremely common, often paired with agitation. And it's so important to remember that these are often direct byproducts of the cognitive changes. It's the frustration, the fear, the confusion.
Yeah.
It's not a separate psychiatric issue popping up.
And physically, they're becoming more dependent.
Increasingly dependent in their ADLs. They need prompting, reminders, help with things like dressing for the weather.
Which brings us to the final stage, stage 3, late or severe.
This is the end stage picture. The patient is completely incapacitated and bedridden. They're totally dependent for all ADLs.
All of them.
All of them. You see a severe loss of both mobility and verbal skills. Communication might stop completely, or it's reduced to sounds that aren't intelligible. And the courses also note that because the brain damage is so widespread, you can see things like seizures and tremors.
And there's a specific term for a key feature of this stage. Agnosia. Let's revisit that. What does that mean in this final stage?
Agnosia is the loss of sensory comprehension. So the person's eyes might see a coffee cup, their hand might touch a blanket, but their brain can no longer process or interpret what that thing is.
So you lose the meaning of the world.
They lose the functional meaning of everything around them. It is the definitive sign of that sensory detachment in the late stage.
Wow. That detailed look at the stages really sets the context for what care looks like. Now, when it comes to diagnosis, the sources listed the usual imaging, PET, MRI, CT. But those are mainly for ruling other things out, right?
That's exactly right. The imaging is crucial for a differential diagnosis. You want to make sure it's not a tumor or a stroke or something else that might be treatable. But the actual diagnosis of Alzheimer's is still largely clinical, based on tracking that history and the progression through these stages.
Okay, so once the diagnosis is confirmed, the source is really focused on four key challenges or prioritized hypotheses that caregivers have to deal with.
Yeah, four big areas of risk and concern.
The first one is the core problem, decreased memory and cognition because the neurons are changing.
Which leads right into the need for medications, which we'll
Yeah.
get to. The second challenge is very practical, very immediate, the potential for injury or falls. This is due to wandering, disorientation, or just being unable to walk safely as their mobility declines.
And the third one. This one was a really difficult reality check in the material. The potential for elder abuse by caregivers.
We have to talk about that. The sources are acknowledging a really harsh truth. Alzheimer's can last for 8 to 20 years. The care needs just increase and increase until the patient is totally dependent.
And that puts this unbelievable strain, physical, financial, emotional injure on the family caregiver.
An unrelenting strain, and that, unfortunately, vastly increases the risk for neglect or abuse. It's a structural reality of the disease. This isn't just about the patient. It breaks the whole support system.
Which is why things like respite care, which we'll cover, they aren't luxuries. They're absolute necessities.
Absolutely. And the fourth priority, especially as you get to stage 3, is the need for really good symptom management at the end of life, ensuring comfort, dignity, and getting palliative or hospice care involved.
Let's focus on the medications now, because even though there's no cure, there are drugs to slow that functional decline. The main ones are the cholinesterase inhibitors. Can you walk us through how they work?
Okay, so to get this, you have to remember the brain communicates with chemicals called neurotransmitters. One of the most important ones for memory and learning is acetylcholine, or AC.
Okay.
In Alzheimer's, the cells that make and use that chemical, ACA, they start dying off. Now, there's a natural enzyme in the brain called cholinesterase, and its job is to break down acetylcholine.
And that's where the drug steps in.
Yes, the cholinesterase inhibitors, they block that enzyme. By blocking the enzyme that breaks down acetylcholine, they delay the destruction of whatever remaining acetylcholine is still there. They make more of it available for longer.
So if the brain is a city losing its highways, the neurons dying, this drug is like a traffic controller, making sure the remaining side streets, the anesthetory, stay open and functional for as long as possible. It makes the decline less steep.
That is a perfect analogy.
Yeah.
And the key takeaway has to be that this slows the onset of cognitive decline in some clients. It doesn't reverse anything. It doesn't stop the underlying disease. It's a symptomatic delay. The expectations have to be realistic.
And what about those behavioral symptoms we mentioned? The paranoia, the delusions, the agitation.
Yeah, the sources made a really critical point about where those come from.
Right.
They're often a direct byproduct of the cognitive changes, not some separate psychiatric condition. The brain's wiring is damaged, it's misinterpreting things, it's creating fear where there isn't a threat.
Which leads to that vital piece of communication advice.
Right.
Don't argue with them. Don't try to use logic to tell them there's nothing to be afraid of.
It's completely non-therapeutic because for the client, the delusion, the fear, it is 100% real. If you try to argue with logic, all you're doing is confronting them with their own inability to reason, and that just ramps up their anxiety and their agitation.
So what's the better approach?
Validation and redirection. Acknowledge the feeling, I can see you're scared,
Yeah.
and then gently change the subject or the environment.
Okay. And on depression, which is a common complication, what's the standard treatment?
When you have a diagnosis of clinical depression alongside the AD, the go-to medications are usually the selective serotonin reuptake inhibitors, or SSRIs. The sources specifically named sertraline, Zoloft, and paroxetine, Paxil, have common choices to help manage that mood component.
Okay, let's dive deeper into communication, because the deficits really define the disease. The sources gave a clear breakdown of those A words, which can be confusing.
Yeah, this vocabulary is really precise. We start with the mildest one, anomia. This is simply the inability to find words. It's that tip of my tongue feeling we all get, but for them it's constant.
Then it gets worse and becomes aphasia.
Right, aphasia is much more severe. It's the inability to speak or understand language. They can't form sentences or they can't process what you're saying.
Next is apraxia.
Apraxia isn't about language, it's about motor planning. It's the inability to use words or objects correctly, so they might try to brush their hair with a toothbrush. They've lost the how-to for learned, purposeful movements.
And the most severe, which we already mentioned, is agnosia, loss of sensory comprehension. It's a profound dismantling of a person's ability to interact with the world.
It is a gradual retreat from reality. So given all that, the cornerstone of keeping them safe but also independent for as long as possible, especially in stage 1 and early stage 2, is all about the environment.
What are the best strategies for that?
Two big things. First, allow them choices, even small ones. The sources said letting them choose what to wear from a couple of prepared options supports their autonomy. But the single most critical intervention is the need for a consistent routine.
Why is consistency so powerful? The sources were really emphatic about this.
Because when your internal memory is failing, your brain starts to rely on habit and procedural memory. A consistent routine provides these reliable external anchors. If you wake up at 7, eat at 8, walk at 10 every single day, that predictability reduces confusion, anxiety, and agitation. A shifting schedule is a recipe for disaster.
Now, what about the huge safety issue of wandering, which is tied to those visuospatial problems in stage 2? What are the non-negotiable interventions?
Identification is priority 1. They must wear a medical ID bracelet at all times, not on the nightstand, on their wrist. And enrolling them in a program like the Safe Return program is a very high priority.
And there were some strong cautions, too, things not to do.
Yes, you have to actively avoid increasing their confusion. So taking them for a walk in a different, unfamiliar neighborhood, that's counterproductive. And critically, physical or chemical restraints, things like sedatives or special chairs, they have to be a last resort.
Only when safety is completely compromised.
Exactly. And all other less restrictive options have failed. The focus is always on managing the environment, not restricting the person.
Okay, let's wrap up Alzheimer's with care coordination, because we talked about that overwhelming strain on the caregiver.
This is all about the caregiver's survival. Resources like home care management and respite care, which is temporary care, to give the primary caregiver a break, are fundamental. And any education we give the family has to be reasonable and realistic. You don't hand a desperate family a 50-page manual.
The example in the sources about a caregiver needing a break was very telling.
Yeah. If a caregiver says they have to leave town for a few days, the only appropriate therapeutic response is focused on support and client safety. You don't question them. You don't make them feel guilty.
You just solved the problem.
You immediately problem solve. You help them find an interim caretaker. You give them resources like the Alzheimer's Association. It's about support, not judgment.
All right. That concludes a really deep look at AD, a condition of chronic cognitive collapse.
And now we pivot. Completely. We're moving from a disease of slow degenerative breakdown to a disorder of acute, sudden electrical chaos. We're talking about seizures and epilepsy.
This is where things get immediate and dramatic. Let's start with the definitions. A seizure is what?
It's an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons in the brain.
So a massive electrical short circuit.
Exactly. And it overwhelms the normal function of the brain cells. The result is a sudden change in their level of consciousness, their motor ability, their sensory perception, or their behavior.
And epilepsy is the chronic version of that.
Yes. Epilepsy is the chronic disorder. It's characterized by repeated, unprovoked seizure activity. And that word unprovoked is key. It means the seizures aren't just a side effect of some acute event like low blood sugar. It reflects an underlying tendency of the brain to seize.
The classification system helps map out where that electrical storm is starting. It's basically broken into two main camps.
Right. First, you have focal seizures. These start in one specific area of the brain. And we classify them based on the person's awareness during the event. So a simple focal seizure means they stay alert and conscious. They might just have some localized jerking or a strained sensation.
But a complex focal seizure involves altered consciousness.
That's the critical difference. In a complex focal seizure, the person might stare blankly. They might do repetitive, purposeless things like lip smacking. We call those automatisms. And they aren't fully aware of what's happening.
And then you have the bigger ones, the generalized seizures.
Right. These involve the whole brain, both hemispheres, right from the start. And they almost always involve a loss of consciousness. The classic example is the generalized tonic-clonic seizure.
What used to be called a grand mal seizure.
Exactly. It has that tonic phase where the muscles stiffen up, often with a fall followed by the clonic phase, which is the rhythmic jerking of the arms and legs.
And there were a few other generalized types mentioned briefly.
Yeah, things like myoclonic, which are these brief, lightning-like muscle jerks. Or atonic, which is often called a drop attack, where there's a sudden total loss of muscle tone and the person just collapses. Recognizing these different patterns is key for diagnosis.
Okay, so let's look at why these electrical storms happen. The causes are broken into primary and secondary.
Right. Primary epilepsy is what we call idiopathic. It's often linked to genetics, and there's no visible lesion or damage in the brain.
Then you have the huge category of secondary seizures.
And these are a symptom of something else that's irritating the brain tissue. The list is long. It could be a brain lesion, like a tumor, or damage from a stroke or the traumatic injury.
Head injury is a huge one.
A huge one, especially if there was bleeding or scarring. But it can even be systemic things like heart disease if it's bad enough to compromise blood flow to the brain. And then you have the toxic causes.
Substance abuse and acute alcohol or barbiturate withdrawal.
Very common triggers with withdrawal. It's this dangerous overshoot phenomena. Alcohol and barbiturates are depressants. When you suddenly take them away, the brain, which has been compensating, rebounds into this state of runaway excitation. And that can easily trigger a massive seizure.
Beyond injuries and toxins, the sources gave a very specific list of metabolic disturbances that can be triggers. This really shows how sensitive neurons are to their chemical environment.
Oh, the brain operates in an incredibly narrow tolerance range. Things like acidosis, too much acid in the blood, can disrupt everything. Electrolyte imbalances are a huge culprit.
Sodium, potassium, calcium.
Exactly. The very things needed for a nerve impulse to even happen. If they're out of whack, the system gets unstable.
And you mentioned low blood sugar and low oxygen, too.
Yes. Hypoglycemia, low blood sugar, means the brain is being starved of its main fuel. Hypoxemia, low oxygen, is also a form of starvation. Either one can cause the cells to just start firing erratically.
So it all comes back to balance. The brain's electrical stability depends on the body's internal chemistry being perfectly balanced.
Perfectly balanced, that's it.
Okay, for assessment, gathering a detailed history is key. But what exactly is the preictal phase?
The preictal phase is the time right before the seizure hits. And it's so important because some people experience an aura. It might be a strange smell, a weird visual thing, or just a feeling that serves as a warning that a seizure is seconds away.
And that warning can be life-saving.
It can be. It gives them time to get to a safe place. Now let's get to the most critical part. Acute seizure management. This is where the practical do's and don'ts are everything.
This is a high-stakes moment. Panic is common, but you have to follow the protocol.
Absolutely. When someone starts seizing, the single non-negotiable high priority is protecting them from injury.
So what are the immediate steps?
First, clear the area. Move anything they could hit their head on. Loosen any tight clothing around their neck. Then, the single most important intervention for their body position, turn the patient to the side.
And why is that so critical?
It's all about preventing aspiration. During a seizure, they can't control their secretions. Saliva, maybe vomit, and if they're on their back, that can go into their lungs and cause a life-threatening pneumonia. Turning them on their side lets gravity keep the airway clear.
Okay, now let's hit the common dangerous myths. The absolute don'ts.
Number 1, do not force anything into the patient's mouth. You can't swallow your tongue. But trying to put a spoon or a wallet in their mouth is a great way to break their teeth, cut their gums, or get your own fingers bitten.
And number 2.
Do not restrain them. Don't try to stop the movement. That jerking is from uncontrolled electrical activity. If you try to hold a limb down against that force, you can cause dislocations or even fractures. You just gently guide them away from danger.
So protect them from the environment, manage the airway by turning them on their side, and then wait. But what if it doesn't stop?
That's status epilepticus, and it's a true medical emergency. When a seizure goes on too long or they have them back-to-back without recovering, it can lead to permanent brain damage.
So the intervention has to be immediate.
Immediate and aggressive. The definitive treatment is IV push benzodiazepines. The source is named lorazepam or diazepam.
And if you can't get an IV?
There's an alternative route. Diazepam rectal gel. It provides the rapid absorption needed to stop that continuous electrical storm. These drugs basically hit the brakes on the whole system.
And beyond the crisis, what does long-term management look like?
The primary focus is non-surgical, and that means strict adherence to anti-epileptic drugs, or AEDs. Missing even one dose can lower their seizure threshold and trigger one.
And lifestyle changes.
Crucial. A balanced diet, getting enough restorative rest, and actively managing stress. Lack of sleep and stress are notorious triggers. And finally, social services might be needed to help navigate things like employment or driving restrictions.
Okay, that wraps our look at the brain. from chronic deterioration to acute crisis. Now let's transition down that CNS highway to the spinal cord where the focus really pivots to mobility and pain.
Right. This final section anchors us in the physical mechanics of movement. And the first most common issue is low back pain, or lumbosacral pain, LBP.
This affects what, something like 80% of adults at some point? The sources define it based on how long it lasts.
Yes, and that's crucial for treatment. Acute LBP is usually self-limiting. It lasts less than 12 weeks. Most people get better with some rest and conservative care. The real concern is chronic LBP, which is pain that lasts for 12 weeks or more.
Because that suggests something more complex is going on.
Exactly, a more structural underlying issue. And the symptoms often go beyond just muscle pain. You get severe muscle spasm and, importantly, paresthesia.
That's the pins and needles feeling, right? The tingling or numbness.
Right. And when you have that, it strongly suggests a nerve root is being compressed. The sources mention spinal stenosis, a narrowing of the spinal canal, as a potential cause for that compression.
Given how common this is, prevention is probably the most effective intervention. What were the simple preventive measures?
Simple, but often ignored. Maintaining proper posture, engaging in regular exercise, especially core strengthening, and practicing good ergonomics.
So setting up your desk properly.
Exactly. Your chair height, your monitor level, all those small constant stresses on your spine add up over years and become chronic pain.
Now, when the pain is chronic, assessment is key. And the sources pointed to one priority question to ask.
Yes. And it reflects a really patient-centered approach. The question is, what helps you to manage the pain?
Why that question first? Why not ask where it hurts or how bad it is?
Because you need to know what their baseline is. What are their current coping mechanisms? What have they already tried that works or doesn't work? It stops you from recommending something they've already tried and failed, and it helps you tailor the next steps.
And beyond that question, you're checking vertebral alignment, looking for tenderness, and really mapping out that paresthesia to figure out which nerve roots are involved.
Correct. And then you move to imaging to confirm. X-rays for major bone issues, CT and MRI for the detailed view of the soft tissues, like a herniated disc, and sometimes an EMG to check the nerve and muscle response directly.
The interventions follow a clear path, right? It starts conservative and only moves to surgery if that fails.
Exactly. When the pain is just relentless and mobility is severely compromised, that's when you start considering a structural surgical fix.
Okay, so let's get into the surgical options. What's the difference between minimally invasive surgery, MIS, and the more traditional open procedures?
Minimally invasive surgery aims to fix the problem, usually removing the piece of a disc that's hitting a nerve with the smallest incision possible. This means less muscle damage and a much quicker recovery. Patients often go home the same day or the next day.
Like a microdiscectomy.
A microdiscectomy, exactly. Or a laser-assisted procedure. Now, the open surgical procedures are for when the problem is more widespread or when the spine's stability is compromised.
This includes things like a discectomy or a laminectomy. Let's focus on laminectomy. The sources were specific about defining that.
Right. A laminectomy is a surgery to remove the lamina, which is the bony arch on the back of the vertebra. Think of the spinal canal as a hallway for the nerves. The lamina is the back part of the roof of that hallway.
So you remove it to make more space.
You remove that roof to relieve the pressure on the compressed nerve root. It's a decompression surgery.
And then if there are stability issues, you're looking at a fusion.
Correct. A spinal fusion permanently joins two or more vertebrae together. They use bone grafts and often hardware, like rods and screws, to eliminate motion at that segment of the spine. No motion, no pain from that movement.
Post-op care for these big open surgeries must be intense. What does that look like?
Early on, it's all about preventing complications. For these major surgeries, a significant recovery period is needed. The sources said a short stay in a transitional care unit or a nursing home might be necessary before they can safely go home.
And the education on restrictions has to be really strict.
Absolutely. The patient has to be meticulously taught the BLT restrictions. No bending, no lifting more than maybe 5 or 10 pounds, and no twisting. Adhering to that is vital for the fusion to heal properly.
Okay, we also had a brief note on cervical neck pain. How is that different?
It's structurally similar, usually a bulging or herniated disc in the neck causing pain, sometimes down the arms. But the treatment approach is very conservative at first.
Meaning surgery is not the first, second, or even third option?
Exactly. The initial treatment is almost always conservative, relying heavily on physical therapy, muscle relaxants, and anti-inflammatories. Surgery is really only considered if that dedicated conservative treatment completely fails to relieve the nerve compression and the pain.
All right. That covers the full journey, from the tangled structures in the brain right down to the mechanical compression of the spinal nerves.
We've covered a huge range.
Hmm.
But if you step back, you can really see this clear thematic link. It's all about the disruption of fundamental control mechanisms.
Absolutely. We started with that slow molecular breakdown of cognition in Alzheimer's, from denial in stage 1 to the total incapacity and agnosia of stage 3. We learned that AD care needs that meticulous coordination, ID bracelets, that non-negotiable consistent routine.
And understanding that paranoia is a symptom of the disease. Then we pivoted to the instant crisis of electrical instability and seizures, where everything becomes about safety and airway management.
Right. Turn the patient to the side, protect the head, and never ever use force or restraint.
And finally, we tracked down the spinal cord, where the core issue was the compromise of mobility and pain. We saw that back pain management is all about prevention first ergonomics, and that when it becomes chronic, you have to find out what the patient already knows works for them.
And we understood the difference between a minor microdiscectomy and major decompression, like a laminectomy. It really shows the lengths you have to go to when structure compromises function.
And in all these conditions, even the best treatments we have, like the cholinesterase inhibitors for AD, they only delay the decline. It demands that care has to be proactive, not reactive.
So, if you were to synthesize all of this, what's the single biggest takeaway for someone trying to understand the CNS?
I think the sources really emphasize that while we don't have a cure for something like AD, and chronic back pain can be structurally very difficult, what we can do is aggressive symptomatic management, strict adherence to therapy, and robust support for the caregivers. That is what maintains the highest possible quality of life.
But if we look at the role of mobility and the impact of chronic pain, that cuts across both brain conditions in stage 3 and the spinal cord issues. What does that reveal as an enduring challenge in all of this?
It reveals that the greatest challenge is the holistic approach. It's easy to get focused on the immediate physical problems, the inability to walk, the trouble speaking. But we have to ensure that while we're managing all that, we don't let the physical demands completely eclipse the psychosocial, the emotional, the relational needs of both the patient and their tireless caregivers. Recognizing that the human spirit is still fighting for connection, even when the CNS is failing. That's the true, compassionate deep dive that has to follow every single one of these medical diagnoses.
A truly profound way to look at it, managing the medical condition while supporting the human condition. Thank you for guiding us through this incredibly complex landscape today.
It was my pleasure.
And thank you for joining us for this deep dive. We'll see you next time.